All right, welcome everybody. My name is Rachel. I am one of the site engagement coordinators with MVC. Give me one second here. It'll be my pleasure to be facilitating the work group for you today. Today is our first sepsis work group for the 2025 year. First off, we're going to start with some housekeeping and some reminders for you guys. I know a lot of you have done work groups in the past, so this should be pretty familiar. First will be this work group session is going to be recorded. The slides of the presentation and the recording will be shared with attendees following the work group. Second, reminder to please double check that your mic is muted throughout the presentation to help reduce any background noise. And then finally, questions. We will be monitoring the chat throughout the presentations, so feel free to add questions throughout. We can try and answer them as they come up, but we also do have a designated time for questions and discussions after each presentation. And then, so that's it for that part. Reminders for our P4P participating sites. We look forward to your active participation throughout the work group, and that includes responding to any polls and discussion questions that are going to be coming up, and then asking any questions that you may have throughout the work group. Additionally, for the P4P credit, we will have the post-work group survey link. We will share that at the end of today's work group. It'll be provided in the chat. It will also be sent in an email with the slides and follow-up information from the work group later today or tomorrow. And as a reminder that if you are attending on behalf of a hospital and you're maybe part of like the system, the health system, just to make sure that you select the one hospital that you're hoping to get the P4P credit for in the survey, and to only submit one survey per site so that there's no confusion for the engagement point accrual. Here's our agenda for today's work group. We started off with our housekeeping and reminders. We're going to be having a presentation given by Munson Health System on improving compliance with their sepsis bundle. Then following that, we'll have the question and answer time with the presenters. And then Emily, our site engagement coordinator, will be presenting on MVC's collaborative-wide goals for sepsis in 2025. And then we do have some discussion questions following Emily's presentation. Today's presenters from Munson, we have Alex Callaway. She's the Director of Quality and Patient Safety for Munson's Community Hospitals. She has experience in quality assurance, patient safety, regulatory, and outpatient operations leadership. We also have Diane Barton. She has been in clinical quality at Munson Medical Center since 2007 and has been the Director of Quality since 2013. She obtained an associate's degree in nursing from Alpena Community College and a Bachelor of Science degree in Health Administration from St. Joseph's College of Maine, as well as a dual master's degree in nursing and health administration. She holds a certificate in healthcare quality from the National Association of Healthcare Quality and is also a certified professional in patient safety. We have Jennifer Bentley, who is a nursing quality coordinator at Munson. She is experienced in medical, surgical ICU, case management, quality regulatory, and is also a local sepsis coordinator. Jennifer facilitates the location sepsis team and is part of the System Improvement Committee. And lastly, Stephanie is also a nursing quality coordinator. She has 25 years of nursing experience, including home care, medical surgical, long-term care, employee occupational health, nursing and community education, infection control, and quality assurance. Stephanie helps facilitate local sepsis teams and is a part of the System Improvement Committee. And with that, I'm going to pass the baton to Alex and Diane to continue with their presentation.
Good afternoon, everybody. Thank you for having us today to speak to you about sepsis improvement processes at Munson Healthcare. If you could move to the next slide, Rachel, we'll go down to the plan. There we go. I'm sure, as is the case with many of you, we use the PDSA model for our performance improvement activities within the system. And we've designed our presentation today around that process. So I'll start the presentation with plan and do, and Alex will conclude with study and act, and then we'll offer time for questions and discussion. So next slide. All right, so improvement of sepsis care became one of our true north driving strategies several years ago, partly because we weren't performing really well in comparison to state and national benchmarks, but also because sepsis was the #1 cause of death for patients across our system. Evidence-based practice demonstrated that compliance with components of the CMS SEP1 bundle was associated with reduced mortality and improved patient outcomes. So we selected that as our true north metric to guide our progress within the performance improvement efforts. And we did set a goal to improve internally as well as in comparison to state and national benchmarks. Next slide, please. So early on, we acknowledged that it was really important for us to engage the right team members to promote our performance improvement activities around sepsis. We strove to ensure that membership on our teams offered a broad representation of those who both delivered care to the patients with sepsis and those who provided relevant support services to those individuals. Subsequently, our teams included physicians, nurses, pharmacists, and also individuals from clinical informatics and quality teams, and even corporate communications at one point. I say teams, plural, because we are an 8-hospital system. We were relatively new to being a system. And we had many different processes. We had 3 different EHRs across 8 hospitals. And so we developed local sepsis teams at each hospital, and then they were accountable to an overarching system sepsis team who was under the leadership of our Chief Medical Officer and Chief Quality and Safety Officer, Dr. Joe Santangelo. We used a problem-solving A3 process to examine our current conditions against what should be happening and to identify why gaps were occurring. Our intent, of course, was to determine countermeasures to address those gaps. Even before we started the process, we knew from the very beginning that we had several barriers. Some of these explain the rationale for having those local PI teams. And among these are the fact that we were operating with 3 different EHRs, all with differing capabilities and clinical flow processes. That was a big one for us. Next slide, please. So in addition to the EHR issues, which included lack of standardized references, lack of standardized sepsis assessment and documentation, we identified opportunities related to provider engagement and adoption of existing sepsis tools, both within and without the EHR. We had developed a paper sepsis toolkit, which was meant to promote continuity of care and support effective handoff as patients were moving across the system. This was used only sporadically. And due to differences among our EHRs, we didn't have a common sepsis alert system. We had implemented the Cerner Sepsis Advisor at the 5 Cerner hospitals, and we were seeing that when used effectively, it did offer a consistent inverse correlation between compliance with the advisor and sepsis mortality. But as I mentioned, adoption was not consistent. While our current state assessment showed that we did have one set of standard interventions that we all agreed upon, the SEP1 bundle, the lack of consistency related to assessments and documentation contributed to varying degrees of success in meeting those standards. Moreover, we did not have a standard model for reporting sepsis compliance to organizational leaders, let alone to those providing the care to the sepsis patients, which is really one of the most important interventions, is letting people know how they're doing and why it's so important. Nor did we have a standard way to investigate fallouts and identify opportunities for improvement. Next slide, please. So that was kind of a very, very high level overview of the general opportunities identified in our current state assessment. I'm going to shift gears from plan to do in order to provide a bit of detail on some of the specific actionable opportunities that we identified. So I'd mentioned that the sepsis advisor was proving beneficial to delivering our standard of care and supporting better outcomes for them, but that we needed to improve its adoption by gaining provider buy-in. One way we addressed this was by establishing a standard for monitoring compliance and outcomes, and then getting that information to the frontline staff in as close to real time as possible. I think, as many of you are also experiencing, one of the barriers is the lag in data collection time and being able to get that information to providers so that it becomes on the top of their mind, the individual case, as well as to help be actionable. Our clinical business intelligence team had developed really rich sepsis content in our business intelligence tool, which we call Munson Analytics. This included provider level metrics related to the sepsis advisor use, as well as sepsis bundle compliance overall. We established feedback pathways for clinicians and at bi-monthly system-wide sepsis team meetings, as well as the local sepsis performance improvement team meetings. We also offered a nursing grand rounds focused on sepsis education and started pulling sepsis education into routine opportunities to meet with nursing, like general orientation, critical care residency, those types of things. One very specific opportunity we identified was that we were often missing the repeat lactate level in a timely fashion. Our order set had it automatically ordered to be drawn and resulted within 4 hours from the first level, but lots of factors contributed to the test being delayed, and many of these were unable to be mitigated. So because we could not mitigate those root causes, we actually changed the order to repeat the lactate level at 2 hours rather than within 4. This allowed us to get the results back in a more timely fashion and still provided actionable information to drive ongoing therapy, as well as even patient placement decisions. Next slide, please. So this slide just shows one section of our A3 document. It relates to the strategies we implemented, how we would achieve them, who was responsible and by when. And then the last column reflects the status at any given time during implementation. And we used a green, yellow, red status tracker. Next slide, please. So this is some of the data that we have within our Munson Analytics tool. With the next 2 slides, I'll just kind of give an overview of that. We did use these to drive performance improvement. In this particular slide, the green bars represent bundle compliance, and the blue bars represents the patients included as eligible for the sepsis bundle. The y-axis to the left of the graph, it's actually covered in blue, but it would depict the count of those patient encounters. And so the top of this graph actually caps out at 120. So you can see that across the system, we were seeing roughly 80 to over 100 sepsis patients monthly. That's a lot of patients that we want to impact. And if we're only meeting a compliance of 60%, that means 40% of our patients aren't receiving standard of care. And so that was really the impetus behind our focus on sepsis. The black dotted line shows the percent of patients with appropriate care as measured by bundle compliance. And the y-axis to the right of the graph would have those percentages. We thought it was important to provide not only the percentage of compliance, but to really focus on those patients and to have a visual interpretation of the number of people impacted by sepsis. Let's see. I would just note that we have at the end of this graph, October through January of 2025. And of course, that data is not complete yet. We did over time note a reduction in variability, which is one of the things that we would like to achieve. It just shows that there is some consistency in the care in which we're providing. Next slide, please. All right, this one actually looks at our attempt to get to a more granular level on provider actions related to the sepsis advisor itself. The black bars show the number of sepsis plans or sepsis advisors initiated by the providers, and the blue shows how many were actually completed. The green line across the top shows the percent of provider notification tasks that were actually completed in the EHR. Right, I'm going to turn it over to Alex now, who will speak about the study and act phases of our performance improvement activities. Alex?
Thanks, Diane. Appreciate it. So we have a lot under study. This has been a project that we've worked on for multiple years. At first, it was kind of individual hospital, then kind of regionally. And as a system, we've been working on this, I think, for at least 3 and probably 4 years as a team. So lots of things that we've been looking at. And just for reference, we're a 7-hospital system. Next slide. So one of the things that we looked at was the use of the sepsis advisor by our providers. Overall, we found that it was inconsistently used. It had functionality that was a bit disappointing to us. We believed that it was able to do some things that it didn't end up coming to fruition. And provider feedback, I phrased this pretty nicely, but I put neutral at best, but was generally negative. It wasn't very helpful for them. They just frankly would prefer our old version, which was the power plan in our EHR. We did, however, have some increases in performance in general. One of those was in automatic lactate redraw, so not missing that because we had a systems change from automatic redraw from 4 to 2 hours, and that helped our compliance to being under 6 hours with the bundle. Our blood culture compliance has decreased as of recently. I'm not sure if you all experienced that with the supply shortage, but we were not exempt from that. However, we're seeing that going back up. It's something we want to continue to monitor. And we also wanted to make sure that we're looking at the right data under study. So in the next couple of slides, I'll kind of talk about that evolution. You saw some of the examples that Diane gave of the graphs that we have. We also look at very specific case data in individual hospital meetings. We've got local sepsis meetings where every fallout is reviewed with that multidisciplinary local team, and that's shared with the nurses and providers as well. So we've got some kind of pie charts about what is each specific hospital's biggest area of opportunity as well. Next slide, please. So under adjust, next slide, please. Some things that we have changed, so you probably saw in that last study slide, we weren't loving the sepsis advisor program that we were using, so we are no longer using that for providers to place orders and follow through for the clinical pathway. This was replaced with the sepsis power plan, and we are now going to monitor the use of the power plan in driving clinical outcomes. We did trial an automatic third lactic acid redraw, depending on what the second one was. We realized that this caused a lot of unnecessary draws. This was direct feedback from our providers because the logic actually had it based on the first lactic acid. So recently we have decided to change that and fix that rather. So it's going to base on the second one. So we'll continue to make sure that's implemented, and then we'll be monitoring that over the next 3 to 5 months. We are fortunately switching our EHR, so all of our 7 hospitals will be on the same record system January 25th, so that's going to be fun, but it really will be helpful for us to be able to monitor all of that. We're also looking post go live of the consolidation onto the same record system of implementing an automatic blood culture order based on when the first IV antibiotic is ordered. So that's something that we hope can be a process change that doesn't rely on individuals to address that. We continue to address specific fallouts like I talked about with our frontline teams and at local committee meetings, and then talk about the themes that we need support with at our system sepsis meeting, where people can make decisions and make things happen more quickly, especially as supported by EHR. And I think that's kind of all we have. Next slide, please. Oh yeah. So the one thing I forgot to talk about was when we looked at studying, what are we measuring? What more do we need to measure? So historically, we've looked at the CMS sepsis bundle data for the most part. There are other things we've looked at, length of stay with sepsis, but more recently, and many of you are probably eligible as well under the Blue Cross Blue Shield Hospital Medicine Safety CQI, looking at sepsis data there. So three of our 7 hospitals are eligible for this program, looking at post-discharge care coordination under our sepsis umbrella of care. This is just an example over to the right of one of our hospitals. I believe it was Grayling, and how we've seen some variation in that. But one thing that we've had success in is adding contact information with our Ask a Nurse program, which is a 24/7 phone number supported by Munson Healthcare, where you can get connected to a nurse to ask about next steps in care, and they can connect us to providers, to resources, make recommendations about emergency care and all of that. The other goal that we're looking at under HMS sepsis, like all of you, is increased use of balanced solutions over normal saline. So we are planning to make a change in our power plan so that that's the default that's selected versus our prior one, well, actually our current one. And then we just need to make sure that from our nursing perspective, our frontline teams are educated on flushing the lines because of compatibility issues with some of those antibiotics. So any questions for us? We're lucky to have Stephanie Bowen and Jennifer Bentley with us as well. They really drive this more than I do, to be frank, and have been really sepsis experts across our system for years. Do you want me to read the questions out of the chat?
I can do that for you.
Okay.
It does look like we have questions. First one's from Carolina. Says, does Munson's EHR include sepsis advisor for inpatients or just the ED? If only the ED, how did you promptly identify admitted patients who needed sepsis order set initiated?
I actually did reply to that if you guys would like any more information on it. The advisor for both the ER and inpatient patients for the providers. We used to place the orders, as Alex mentioned, through the advisor. We now, as of December 3rd, place them through the sepsis power plan, which they used in the past, and how they place all their other orders for consistency.
Perfect, thank you. Another question that was in the chat that Diane answered was, what EMR are you switching to? And it looks like it's going to be Oracle Cerner. So that seems like that's answered fine. And then Zachary McNamara asked which version of Meditech is currently in use at the facilities.
I actually
Diane had
I
mentioned.
can look up our more recent leapfrogged data, but I'm not sure the version of Meditech. I apologize.
Okay. I can't remember which version either, but it's not the latest and greatest. It has fewer of the bells and whistles.
And I would just add to Stephanie's response that the fact that we want to identify patients that are already admitted to the hospital for sepsis is why we added that third lactate, because sometimes the first lactate is normal, the second one is elevated, and there was no way to, providers don't remember then, oh, I need to get another lactate, so that we can identify those patients who were already admitted. It was very unfortunate that the logic did not allow us to predicate that third lactate level off of the second order's results. That is something that we will continue to work on after January 25th, when we all go on the same EHR and the dust settles from all of that. But we definitely want to be able to continue to offer the patients who are already in the hospital the same level of care that they would receive had they come into the ER.
Okay, it looks like we have another question from Daniela Marson. Can you explain a little bit more about the process you would like to implement for the blood cultures to automatically be ordered based on the first antibiotic order?
Steph, do you want to take this one? And I think it's based on the administration, or is it the order?
So what we tried currently at some of the facilities was to have the Pyxis system. When you pull the antibiotic, it does, I mean, currently this is our process. It does alert the nurse that the blood culture has to be completed. But then the issue is sometimes it's completed, but they can't see that it's completed, or if it's not been done by the ED tech. And we do have a different process for it, and Grayling, the ED tech, draws it. We're looking at doing that at other places in the system as well. Generally, we tend to miss blood culture draws less using the ED techs versus trying to get the lab to get them. So right now, that is our process. Moving forward in the future, we're not sure how we're going to do it, whether it's going to be triggered through pharmacy with that first antibiotic order, or using Cerner. And it's just something we started talking about as it wasn't quite as much of a priority as the lactic acid, the antibiotics within 3 hours. So as we solve some of the issues that were affecting our compliance, we are trying to work on other issues.
All right, thank you. It looks like Joy Sill has a question. Does your program provide trending data for nurses, like elevated white blood cell count versus and VS, et cetera?
I work in one of the Meditech hospitals, and we are able to trend our vital signs from our screens. And you can also sort of do that in Cerner. It's just a little different view. There's not a great graph or anything that pops up like that, but typically you're able to see a fairly wide time span on our screens.
And if you are a Meditech hospital, I'm not sure what the settings are by default, but we learned in Gaylord that there's a sepsis special panel that shows some of that trending in most recent values that relate to sepsis, and that was turned off. So they ended up turning that on and making it accessible to all of the nurses about a year ago. Of course, now we're switching, but we didn't know that we had it. So interesting functionality if you have Meditech.
Thank you. There's a question from Julie that is, are you finding the fluid orders from the ED versus current in-house patients meeting best practice?
We've had very good results with the fluid orders. We've done a lot of education on educating our ED providers, especially because that's at the facility I'm at. That's where like 99% of our sepsis patients do originate, is through our emergency department. So we've done a lot of education on, what is the appropriate amount of IV fluids. We tailored our order sets to include different options. And then we also gave them some canned text that they could use so that they could easily incorporate that into their documentation to justify why they were giving a lower volume.
And it's similar for the Cerner hospitals, and I think a little bit easier to actually document reasons why we're ordering less fluids, which is pretty new with CMS from maybe 3 years ago, where you could actually order less fluids and document the reason why. And I think the other question was if the ER follows the orders better than the inpatient providers, and that would be yes. And I think sometimes there's just some confusion also where they think the ER gave it. And then they say that and they document that it was fluids were given in the ER, the fluid bolus, and it maybe wasn't completely, or the provider didn't order it. So there are communication issues. So I think it is a struggle probably for everyone.
Let's see. Any struggles with implementing the reflexive lactate order? Stacy Sparks says they're working on this at their facility, but have had some technological challenges.
We really didn't have an issue in the Meditech version, or I don't think we really had the issue with the Cerner either. it wasn't that difficult of an implementation. My lab staff were able to build the order, and in the background, there's a rule that if it's, greater than 2 for that first lactate draw, then we draw the second one in 2 hours. And then we actually have we have 2 lactate orders. You have a standard lactate. So if you have an outpatient or just someone who only needs 1 lactate, they can order that order. But then for our sepsis patients, we named it lactate with reflex in 2 hours. And it actually went very smooth once it was implemented.
For the Cerner hospitals, it was not difficult to have the repeat order for the second one, but the third one is proving to be a little bit difficult because it needs some scripting that's written. So we have a project request in for it.
Thank you. We've got a question from Abigail. Now that you're no longer using the Sepsis Advisor tool, have you instituted a new alert screening process for identifying sepsis patients? And then do you have a proactive sepsis screening tool in place that nurses and providers can use to identify these patients early?
Yes, we are still continuing to use the Sepsis Advisor tool itself. So it still notifies, and it notifies based on the sepsis screening tool, which we used to call St. John's tool. So when nursing addresses the alerts that fire on the sepsis tool, then the advisor will go ahead and fire and notify the providers still, but then they just place the orders now through the power plan instead of the advisor.
Looking through here. Carolina is still curious how the Sepsis Advisor and Power Plan function. Are they at times triggered when patients actually do not have sepsis? We have sepsis alerts, but very often they fire excessively or inappropriately. Do you have a similar issue, or do you encounter alarm fatigue?
I'm not sure who wants to take it, but yes, it fires no matter what. It does not discriminate whether the patient has an infection or they don't have an infection. So they do absolutely get fatigue, but I think we've had it at this point so long that they're very comfortable with the alert firing. They can very quickly look at it and either disregard it or address it. So I think at this point, the alert fatigue from that particular this actual screening isn't so bad. However, for the providers, the advisor, those alerts where they constantly had to place the orders because it kept asking them to place the orders over and over and over again, that alert was very, it was difficult for them. So they would just completely ignore it and just dismiss it. So our hope is having to place the orders through the power plan, and it's not dependent on them completing the orders. Once the advisor fires, they see it and they address it through the power plan, then it won't fire anymore.
One of the things we did when we re-implement the power plan is we entirely reorganized it. And so it very much follows the logic of the things you need to do to provide the right care for the patient. And that has been so far well received. And of course, we'll continue to get feedback on that. But that was, I think, an integral part of the action that we took after studying, why didn't it work before? Now people liked it because it wasn't the advisor, but how are we going to make it work for them? I have just a fun thing to share. I know Pat Posa's on the line, and I think one of the biggest initiatives of the Sepsis Alliance and other healthcare professionals is to really promote awareness of sepsis. And so there is a new TV series starring Noah Wiley of ER fame. There's only been 2 episodes so far. The whole series is over 15 hours in one day in an emergency department. And in the first episode, he's got residents and students, and they get this patient in, and he says, "Page a code sepsis." And the resident looks at him like, "Code?" And he's like, "The government is watching. We better get this right." Which I didn't agree with his response, because it's not about getting the metrics right. It's about getting the care right. But it's out there. It's now in, it's on TV. Sepsis is a thing and people are aware of it. So just thought I'd share that.
Awesome. Thank you, Diane. I
Hey,
think
Diane, thanks
Okay.
for sharing that. What's the name of the program?
It's called the PIT, PITT. It's set in an ED in Pittsburgh.
And isn't it on Netflix or something?
HBO
Oh.
Max.
HBO Max. Okay.
Yeah.
very cool.
Thanks.
It looks like, let's see, Irene had one last question. Would you be able to share the revised power plan? Is that like you want the name of it or not sure, maybe one of the Munson team can answer that.
We can look into that
Okay.
and send it out.
Yeah. Yeah.
An
We have,
example.
it's a power plan, but we have it as like a Word document that we could share.
Okay.
Yeah, we really pared it down from what we had before. The prior power plan had every eventuality and every test that they thought the providers might need versus here is what you need for sepsis. And so we really pared it down, and we have some headers in there with instructions within the power plan. So as they're selecting their orders, they can be reminded, oh yes, I need my antibiotic, I need this, I need this. And we have our broad spectrum antibiotics tied to potential diagnoses. So if they have pneumonia, here's what we recommend based on our antibiotic biogram. Or if you have a UTI, this is the recommended that would also help meet the measure.
Yeah, we also have a sepsis checklist that people have used. Some hospitals aren't using it anymore, but I know that there was success for those who did, at least during some periods. So we'll share that if it's something you're interested in too, just a paper document.
Great. We do have another question. I think this will be our last one, and then we'll have to move on to our next portion of our presentation. From Carol, are you doing anything to help educate the community in your area about sepsis?
I would say for the most part, we do a better job of educating our healthcare team. I think during Sepsis Awareness Month, we might put a couple of things out on our like social media pages, and we may have one of our physicians talk about it on a radio station or with some local programming. But that's kind of the extent. Diane, any other thoughts there?
No, I was just thinking back prior to the pandemic, we had a lot more avenues that we took advantage of, and we probably need to kind of shift that gear again and get back towards that. So.
Well, thank you so much, Diane and Alex and Stephanie and Jennifer, for that presentation. And that was a wonderful discussion. Good questions, everyone. And now I'm going to be handing the reins over to Emily, the site engagement coordinator with MVC. We're going to be going through some of the new MVC collaborative-wide sepsis goals for 2025. Emily?
Awesome. Thank you, Rachel. And thank you again to Diane, Alex, Jennifer, and Stephanie for that wonderful presentation discussion. I think this has really sparked some great questions and thoughts, and we want to keep that going by taking note of a couple of MVC-related sepsis updates. Next slide, please. Okay, so just a reminder that the MVC component of the BCBSM P4P program works in 2-year cycles. So now that we are in 2025, we're looking at this being a performance year for program year 2026. So related to those 20-year program year 2026 and 2027 metric selections that your sites recently made. Next slide. Okay. So as was mentioned at our fall collaborative wide meeting, and then perhaps if you were involved in P4P selections, you might have noted this during the most recent program year 26-27 P4P selection. A change was made in the sepsis value metric from program years 2024-2025 to program year 2026-2027. In order to better align with the HMS sepsis measures, the MVC sepsis value metric was transitioned from a 30-day risk-adjusted readmission after sepsis to 14-day follow-up after sepsis for program years 26 and 27. And as you can see on the slide here, we saw a really significant increased interest in this new sepsis value metric for program years 26 and 27. So on the left, you're seeing just 5 sites that selected the previous program year 24-25 sepsis metric, and up to 19 sites that selected the new 14-day follow-up after sepsis metric. So we were really excited to see this, given that it is a new metric option. And we're curious sort of about who's sort of in the room right now, and who might be represented in these sort of program year 24-25 selections versus the program year 26-27 selections. So I'm going to pop up a poll. And I'm going to launch that. Hopefully that is showing up on your screen now. So that first question is just a curiosity about whether or not your site, if you know, selected the sepsis measure for program years 24-25. The second question relates to, if you know, did your site select the sepsis metric for program year 26-27? And then the very last question down there is inquiring as to how well MVC's P4P sepsis measure aligns with your internal priorities on a scale of 0 to 5, 0 being the least alignment with your internal priorities, and 5 being the greatest alignment with your site's internal priorities. I'll give you a minute or two to fill that out. I'm seeing those blue lines kind of moving around. And just as a reminder, participating in these polls and the discussions is a part of how we're sort of evaluating engagement with our work groups in 2025. Still seeing those numbers rise, so I'm gonna give you one more minute here so we can collect all that info. Great. Okay, so it looks like we're pausing. Looks like we have pretty good representation of the sites that selected that previous sepsis measure for program years 24 and 25, with 29 out of the 36 respondents. Oh, sorry, I flipped that. Selecting no, it's actually a smaller group represented here. And then we've got 14 of the 36 respondents representing those sites that did select program year 26-27 sepsis selection. Great. All right. And then looks as though on a scale of 0 to 5, the new P4P sepsis measure is aligning fairly well with most respondents' internal priorities. Okay, sounds great. Thank you so much. I will share those results with everybody so you can see them. Sorry, I didn't realize I didn't do that before. All right. Great, and I think we'll move on to the next slide there, Rachel. Great. Okay, so next, we just wanted to share a little bit of MVC data on this 14-day follow-up after sepsis metric. Later this week, your sites are going to be receiving access to a new MVC push report. We're calling this a process measures push report. And this may potentially include your hospital's 14-day follow-up after sepsis rate data, as long as your site met all of the requirements for inclusion of that report. So on the next slide, I'm going to show you a couple of graphs, and just to give you a little bit of information as to what data is being included in these graphs that Rachel is now showing you. That actually works really well, Rachel. So the patients that were included within this rate are 30 and 90-day inpatient or surgical episodes of care for adults with index admissions between January 1st, 2022 and December 31st of 2023, so a 2-year span. The patients that were excluded from this rate would be patients with an inpatient hospital transfer, those that passed in the hospital during their index hospitalization, or those that were discharged to hospice. And the data sources that are coming into this rate include Blue Cross Blue Shield of Michigan PPO commercial and MA claims, Blue Care Network, HMO commercial, and Medicare Advantage claims, Medicare fee-for-service claims, and Michigan Medicaid claims. Okay, now we're already looking at those graphs. I did just want to note on there, so what we're looking at is the MVC all rate noted there on the blue dot for 14-day outpatient follow-up rates amongst patients hospitalized for sepsis. And so you might be able to see that, but it's sitting just under about 60%, 57.9%. And you can see kind of the spread of the collaborative sites ranges around 20% to about 68%. And then in the second graph, we're seeing the MVC all rate, which is the yellow line actually. The blue line is just a blinded site. For 14-day outpatient follow-up rates over time, so over that 2-year span. And you can kind of see that it's remained fairly stable at about 60% over those 2 years. Great. All right. So kind of want to just finish up this section of the presentation with some discussion. We had a couple of different options depending on who was kind of present for this presentation. And it sounds like we've got representation from folks that selected sepsis for program years 24-25, as well as for program years 26-27. So we're sort of curious, maybe we'll start out with questions related to 2025. Wondering if anyone would like to share your organization's goals related to sepsis for this upcoming year, and what strategies you may plan to implement to successfully reach those goals. Anybody would like to unmute? Or I'll now take a look at the chat and see if anything came through on the chat.
Hey, Emily, it's Irene Johnston.
Hi, Irene.
Hi. For 2025, we have not set our goals just yet,
Okay.
but it's more of deeper diving. Where I anticipate we'll be going is looking deeper into where our fallouts are, and then trying to improve in those areas. It's narrowing in. We've done quite well last year, maintaining about a 70% compliance rate. So we want to try to take it that next step further and
Yeah.
really start looking at our power plan use and some of those things. So that's kind of where we're sitting right now.
Yeah. So it sounds like building off of, what you did in 2024.
Mhm. Yep.
Do you feel like there were any key strategies that, made you so successful this last year that you're planning to carry through?
I think a lot of our success was from 2023, where we created some of our educational tools and cheat sheets for the nursing and provider staff to use. And then I have interest in that power plan that Munson had spoke of. So I'd like to see how our power plan kind of compares to that, and then if there's any room to improve how we have our thought process in that, and then start also watching to see how often our power plans are being used. I have not started doing that yet, and I'd like to see if that plays into it.
Great. All right. Anyone else on the call kind of in a similar boat to Irene in that you're planning to sort of pull through your strategies for success from 2024 into 2025 and would wish to share what those successes or if you've had any barriers may have been?
Hi, Emily. Christina from Corewell Health.
Hi.
Much like Munson, we have established one epic across all of our sites, which are East Region, South Region, and our West Region, which is a lot of sites, a lot of different hands in the pot, if you will. And so we've aligned those and then reestablished our order set and our interventions to align with our new, our vision as one system. But I think, and there's some comments from our team in the chat from Sarah Chung, but I think one thing that we really are focusing on beyond our ED is our inpatient sepsis patients, and that seems to be really hard for us to capture. So then establishing practices and then finding what works best so that we can standardize throughout our system and kind of come together as one so that we can meet the needs for our sepsis patients. It has been a barrier in the past, but certainly something that we're putting front and center for 2025, as well as order set compliance with our providers.
Great. Thanks so much, Christina. Okay. Apologies.
Hi, this is Stacy Sparks from
Stacy.
Henry Ford Jackson Hospital. So to answer option one, question A, I would say our biggest goals have been obviously step one compliance, and then also septic shock mortality reduction and sepsis readmission reduction. So those have been our main focuses. We've had many different process metrics implemented throughout 2024 to help affect these goals. However, I feel like our major one has been a process for early identification and treatment, so activation of a code sepsis process. We've had one established in the emergency department for a long time. However, we've really made a push for the inpatient units as well, because we do see our gaps tend to be in that area, which it sounds like other hospitals struggle with that as well. So we have really implemented that to get that early identification and treatment, and we're hopeful that that will have some downstream effects to assist us with reduction of the mortality, readmissions, and of course, improving compliance.
Great. Thanks so much, Stacy, for sharing all of that. Sounds like some common threads coming through for most folks. Great. I'm seeing that some folks have been sharing their thoughts and plans in the chat. So Kristen Smith, looks like we've designated a clinical and physician champion for their organization, completed the core elements assessment tool, I believe that's from HMS, and identified strengths and weaknesses of the sepsis program, created a process to improve fallouts on blood culture collection prior to antibiotics. All right. The Michigan Health System, per Christina, is working on an A3 to align with the HMS performance measure for discharge care coordination. And Lisa Snapper noted that our organization's 2025 sepsis follow-up goals are to add our hospital's contact information to our discharge instructions as an added resource for our patients. Great. Getting some really great comments in here. I'm not going to read them all out loud because I'm sure you guys are sick of hearing me chat, and I want to also give Rachel a chance to kind of finish up the work group before 1 o'clock, just with some updates for future events. So thank you so much for the discussion and everyone that is adding notes into the comments. Feel free to keep doing that. And I think we're going to plan to try and collect these somehow so that we can share them back out to you so you sort of know what each other are working on this year. So Rachel, if you want to take the slides back, you may.
All right. Thanks, Emily. All right, so we are going to just go over a few upcoming work groups and event information. Our next work group will be a Health in Action work group on Thursday, January 30th, from 12 to 1, again on Zoom. This work group is going to be with Amanda Biskner from Tri-Hospital EMS. We will be having a presentation from her on the community paramedicine program that she helped establish in her area. So that should be very interesting. We have a couple of work groups in February, the cardiac rehab work group on February 11th, another health in action work group on the 27th. The one on the 27th is actually a follow-up to the collaborative wide meeting presentation that our own Jana presented on for the post-discharge follow-up talk. So this one will be a good one to attend if you were able to go to that at the collaborative wide meeting in October. And then in March, we have a rural health work group on the 11th, and then another post-discharge follow-up work group on the 20th. And then, as you can see, April, preoperative testing, another health in action. And then, very important, we have our spring collaborative wide meeting on Friday, May 9th. We will be hosting this at the H Hotel in Midland, Michigan, again this year. Information for that will be coming out, I think, later in February for registration information. We do have a call for presenters for the collaborative wide meeting and also work groups throughout the year, which I will be going over here next. So you can see at the bottom here, call for presenters. We have a presentation proposal form that is linked on our website. I will also be sending it in the follow-up email to this work group so that you can submit any presentation ideas that you might have, and then we can kind of go from there. Upcoming events, we do have our new preoperative testing registry webinars coming up. The first one will be Tuesday, January 21st from 12 p.m. to 12:50 via Zoom. And then the next one will be Tuesday, January 28th from 12 to 12:50. We encourage you all to, if you're interested in the preoperative testing registry data that is going to be live, that you should go to this and you'll get a good tutorial on how to access that and what you'll be able to see. Our MVC process measure reports are expected to be sent out by the end of day on Thursday, January 16th. So keep an eye out for that notification. And then our P4P final scorecards will be ready in Q1. The final send out date is to be decided, but definitely keep your eyes open for that notification as well. Again, thank you to our presenters from Munson. Thank you everyone for having such an engaging discussion. We really appreciate you all being here, and I hope you all have a great rest of your day.